Folks, I am thrilled to welcome my partner and host for today's discussion, Steve Loberbaum. Did I get it right, Steve?
So close, Steve. We'll go with it.
Okay. Steve is with Assisting Hands and has been just an invaluable part of the community, especially when it comes to these discussions, to help me bring interesting and dynamic speakers and topics to our community. And we've teamed up on a bunch of these that I just think have been amazing. And the thing that I like the best, Steve, is that I get to jump behind the curtain and just work the computer and let you take the role of host, which for me is great. And I know for some people on our platform, they're really excited to get a break from me moderating a lot of these things. But Steve, before I duck behind the curtain, tell us a little bit about yourself and Assisting Hands.
Great. Thank you, Steve. And it's great to partner with you. This is a great forum for us to get information out to help educate people. And really, I started Assisting Hands a little over 10 years ago. I'm a retired lawyer, and I got into this really because I had two parents aging in New York. They both had cancers. And my brothers and I made just a ton of mistakes because we just didn't know. We didn't even know what we didn't know. And so Assisting Hands grew out of that and the need and desire to help educate people so they didn't make the same mistakes that we do. Assisting Hands is a private duty home care company. So we serve all over Montgomery County, the northern part of Peachey County, and in northern Fairfax County, Virginia. And we just help people age in place, wherever place is. It could be a hospital, it could be a rehab, it could be a private residence. But this is the part that I'm passionate about, is helping educate people so that when they do, in this particular instance, discharge from a hospital, they know what to expect and they know the right questions to ask, because that's the most important part. It's a very stressful time. And our job today is to help peel back a little bit of the layers and confusion and to help us out. And so I've got Jenna Capel, who's with Shady Grove. She's a care navigator. And Jenna, I know I may have botched your last name. I apologize. But thank you for joining us today.
Thank you so much. It is such an honor to be here to talk about this important and I think very emotional topic for a lot of people. And I have to say that the source book for positive aging is something I continue to rely on so heavily in my current role and in every role I've had as a social worker. So I'm so honored to be here today.
Thank you. So look, let's jump right in a little bit and tell me a little bit about your background. Are you a social worker? Is that the kind of thing that's required? What's a care navigator do?
That is a great question. So my current role, I work at Shady Grove Medical Center in Rockville, Maryland, and I am what we call a care navigator. Hospitals across the country now, I think, tend to have similar roles, but at every facility, you will see it called something different. Probably the most intuitive name is a discharge planner. And we can get into what that is. I think that's what part of this webinar is all about, is what does a discharge planner do and how do I utilize them effectively? I happen to be a social worker, but I think the trend that I see across the country is the role tends to be filled by a social worker or a nurse, often with bedside nursing experience. So a nurse who perhaps used to work at that same hospital when they graduated nursing school and either learned so much and wanted to move on in the career to do something different, or a lot of times retired nurses who just can't be on their feet so much, but have all this knowledge of what it looks like to help someone through their hospital stay, apply it from a discharge planning perspective.
Gotcha. So look, this is generally, whether it's a planned or an unplanned visit to a hospital, it's a very stressful time for both the patient and for the family who, especially if it's unplanned, is now confronted with, what do I do next? And we've talked off screen a little bit about the role of the hospitalist. So if you don't mind, tell me, what's the difference between the role of a hospitalist and the role of a care navigator or a discharge planner?
So I think it's helpful. I think it is really helpful to think about all of this in the context of who is your care team at the hospital. And for every patient, that's going to look different. But there's usually a few core components. I think everyone tends to be familiar with your nurse because your nurse is the woman or the man or the individual who's in and out of the room, giving you your medications, changing your bandages, getting you on a stretcher to wheel you off to a procedure. Nurse, we tend to know what a nurse is. A hospitalist can also be known as a hospital attending or just plain old doctor. So, a hospitalist is your primary doctor in the hospital. And if you're in for surgery, often that's a surgeon, but let's take surgery off the table for now because that tends to look a little different. But when someone is hospitalized, there's usually one doctor who is primary responsibility for what is happening to you while you're in the hospital and for advancing your care to get you out of whatever crisis got you there. You tend to see more than one doctor. Many patients tend to see more than one doctor when they're in the hospital. The same way that many of us, if we're doing what our insurance is telling us to do, we're going to our primary care doctor. And if something seems off and it's beyond that individual specialty, they will refer you to a cardiologist or a neurologist or a nephrologist. And it is the same way in the hospital. So if it's your heart that's giving you the trouble, your attending, your hospitalist, your primary hospital doctor will be following you along, but a cardiologist will come in, or an advanced practice provider, a physician's assistant, or a nurse practitioner from the cardiology practice will also be coming in to see you. Also, part of that core care team, and again, this is probably not true at every hospital, but locally I find it to be pretty true, and I think it's pretty consistent nowadays across the country, is there will be someone, a discharge planner, a care navigator, a care manager. Those are all terms that I hear, who could be a nurse or a social worker. And their job is primarily to help make sure that when it does come time to leave the hospital, there is a safe plan in place for the patient. And that involves working with whoever is in the patient's world, the patient, the family member, if that individual lives at a nursing home or an assisted living already, with the nursing staff at that place to make sure that whatever destination they are hoping to get to, that the appropriate services and resources are in place to remain safely in that setting. So with the goal of being able to continue your life outside of the hospital.
Okay, so I'm in the hospital, and obviously this will vary because somebody could be in the hospital for just one night or for an extended period of time. When would I expect to hear from a care navigator or a discharge planner? Is it right at the very beginning, or is it 5 hours before I'm walking out the door, or somewhere in between?
So I'm going to speak in the ideal scenario. And I think what we're all really striving for. And I think a lot of hospitals, they're tracking, there's metrics and dashboards that show this, but ideally within 24 to 48 hours, the patient, if it's a loved one who's acting as surrogate decision maker, running the show, um, will hear from the discharge planner, social worker. I'm going to say social worker because I'm a social worker, but I want it to be clear in many scenarios, it will be a nurse, not your bedside nurse who's giving you the medication, but a separate nurse.
Gotcha.
Will reach out within 24 to 48 hours and do what they call an assessment, where we will ask you questions as mundane as confirming phone numbers, the address that you live at, who your primary care doctor is, ranging to topics to what is your mobility at home? Do you use a walker to get around? Do you have are you bed confined already and you have a hospital bed? Are you receiving any services inside or outside the home? So, for example, someone who's been hospitalized in the past couple months might have had home health services arranged. So, a nurse to check on them once or twice a week, physical therapy, even in the home. We're trying to gauge on what has life looked like for you before you got to the hospital. And in that same moment, if there is enough information or even minimal information, we will try to start a discussion on what the goals are for when it does come time to leave the hospital. Because if anyone on this call has ever themselves been discharged from a hospital or had a loved one or a friend or a neighbor in the hospital, things sometimes change very quickly. How one day the doctor will be talking about how the labs don't look good, or physical therapy will come and say, "Hey, I don't know if you're ready to go home alone." But the next day you'll wake up and the doctor will come in and say, "Today you are medically stable for discharge." So that's why we try to get as much information as we can from day one or sometimes day two on what supports you already have at home so that we can start using our experience and our resources and our connections to make recommendations and even start with your partnership to get a plan rolling to make sure that those necessary supports, or at least as much as we can predict, is going to be waiting for you on that day of discharge.
Okay. So if I'm going, let's say for now, I'm going to go home and I need a hospital bed on my first floor because my bedroom is upstairs and I can't get upstairs, that would be a discharge planner's job to arrange for that to be delivered and set up.
Absolutely.
Okay. And so other durable medical equipment, if I needed an oxygenator or something like that, a wheelchair, a walker, those are things that the discharge planner, social worker would be helping me get in place before I go home.
Absolutely. And some of that is going to be necessary to already have arrived at your home before you get there. So, for example, oxygen. In many cases, if you need oxygen and you didn't need it 3 days ago, we want to make sure that oxygen is waiting for you at home when you arrive. And we are also the ones who will suggest and start talking about what are ways to get home that are safe so that you can have oxygen in the transport. Other things we can even sometimes provide to you in a hospital. I think many hospitals store walkers, which is probably the most common medical equipment, just because lying in a hospital bed, even for someone who's totally independent, walking independently, lives alone, often if you're over the age of 60, 70, 80, and you've been in a hospital bed and walking much less than normal, you're going to be a little bit unsteady on your feet. And I think that often catches people by surprise, which is why we're often ready with the walker and with physical. And we also will often be the ones to suggest physical therapy assessments while in the hospital for those patients. So, in addition to suggesting for what happens next, we are also looking for ways constantly to get more information to help us make that right plan for you. So, another big part of our role, in addition to talking to patients and their families and their caregivers, is to be in frequent and constant communication with the bedside nursing team and with the doctors, because the doctors often will have pretty decent information for what kind of medications we're going home with. They can help us predict, will this be 3 days in the hospital or will this be 3 weeks in the hospital, even though things change on a daily basis? And they can also help with recommendations because, for example, I work on an oncology floor in the hospital. For some of our oncology patients, our goal is to get them back to the home setting so that there are no breaks in their radiation or chemo treatment because many facilities cannot accommodate patients on those treatments. So if we know the oncology plan of care, day one, what your oncologist has in store for you for the future, that will help us talk to you about medically how perhaps if we can make it work and put the right resources in place, the most appropriate discharge setting for you might be to go home.
Gotcha. So let's assume I need to go home and I don't need specialized transport. I just need a ride home. Is that something that you all provide, or is that I got to figure that out on my own, either a friend or an Uber or whatever the process is? Or is that something that you would also deal with?
That's a great question. So nowadays, I think things used to work a little differently. Nowadays, in my experience, hospital budgets are very tight. I think 10 years ago, hospitals were more commonly booking rides for patients. What we do is we will help think through what are the options available to you. Many people don't realize, but with different commercial insurance plans, there is transportation, medical transportation included in your insurance benefit. So sometimes we will suggest things and can call insurance with you to find out. We can also work with the nursing staff and the doctors to help predict when a discharge or what time a discharge will be so that you can call around to friends and family to see if there's someone to bring you home. But of course, if someone cannot get home from the hospital, it is absolutely in our realm to help with that transportation and schedule that transportation.
And let's assume I'm going to go home and I need some supplemental skilled nursing service, whether it be OT, PT, speech, wound care, catheter care, some type of care. I know you all will help arrange that, but do you give people a list? Do you just pick a company? Do people have choice? How does that work?
So ethically, we are obligated to give choice, and we should be giving choice. I think a lot of hospitals or health systems are affiliated with their own home health agency. So often we will suggest that if there is not a preference from the family, because a list can be very overwhelming. And often, if we offer a list and it is declined, and in my experience, I am often told to choose a home health agency, which I am not allowed to do. It must be the patient and family's choice. If that happens, if someone has had experience with an agency that they liked, I will always recommend for them to go back to that agency, especially if that experience was recent. If a patient needs, for example, Foley care, and we can talk about the other things that go into that besides a home health agency. If someone goes home with a Foley catheter and it's new to them, it's best practice to have a nurse helping out at home. The nurse that we arrange that can be covered from insurance will not be a 24/7 nurse or even an 8-hour day nurse. That is someone who will probably come for an hour, maybe 2 hours a week, often less, to check on how things are going, to ask the right questions that will help them unveil if there are any red flags, to look at what is happening with the Foley catheter. They might make adjustments in the moment. They might recommend calling the doctor's office, which they might do with you there, or in very severe circumstances, they might suggest calling 911. But the idea is that there's someone with medical expertise coming into their home, because most of us, or many of us, do not have nurse partners or doctor children in our family, though many of us do. And it's that extra set of eyes. So we are the ones who will arrange that home health. And often, if someone doesn't have a preference, I might recommend using the service affiliated with our hospital, because they have access in most cases to the medical records on file for the patient. Otherwise, an agency that I refer to is really dependent on the precise clinical notes that I have sent from the hospital. They also have looser connections to the discharging hospital. So if there are questions, it's not quite as easy for the nurse to reach the attending physician who discharged the patient. But that said, it is absolutely the patient's choice. And we have lists of if skilled nursing facility is recommended or inpatient rehab is recommended.
Let me get to that now.
Yeah.
So that's the next question I have for you. I was slowly walking my way
Okay.
to, there's a decision or recommendation that someone go to a rehab facility to continue post-hospital discharge recovery. And there are a myriad of choices. Someone sent me a list yesterday from a hospital that had 40 different choices and said, Steve, which one would you go to?
Mhm.
And I have some familiarity, so I gave my recommendations, but how does it work? Again, is it up to families? Should families be calling around? Are you making a recommendation to say, hey, here's the list, but we think these guys are great? Is it subject to a bed availability? Do you help with that placement? How does that work?
Okay, this is a really good question. So I'm gonna tackle this from different parts and let me know what I've missed. So often a recommendation for skilled nursing facility at time of discharge, it could be driven by a number of different things. And I think it might be helpful to understand the background. Do you agree, Steve? Is it okay to
Yes.
Okay. So in one scenario, and a very common scenario with the patients I work with, is a patient there will have been a change in mobility that is either visible to us in the hospital based on what the patient has described. So, for example, the patient says, oh gosh, I was walking independently before I got here, and now it's been a week and I'm barely getting up. I don't know if I can walk. And so hopefully before that, we will have had physical and occupational therapy evaluate the patient in the hospital, and they will make their recommendation if the patient is safe to go home independently without services, if the patient might benefit from outpatient therapy, so driving to a clinic to get physical therapy, if a patient might benefit from physical therapy in the home, which we've talked about a little bit as part of that home health service package, or if the patient might need a more either aggressive rehab to help get them back to their independence or a higher baseline than they're at now, or a slow and steady rehab regimen where they'll be in a supervised environment with a staff that helps you get to the bathroom and administers your medication until you're ready to transition back home. So that's one common scenario where skilled nursing facility, also called subacute rehab, that's one and the same. So subacute rehab is a rehab that takes place in a skilled nursing facility. Most of us think of skilled nursing facilities as nursing homes. Another scenario is if there is a new nursing need for a patient that they didn't have at home, often if they're often it is helpful and it's not always needed, but for a patient who's not quite independent or needs more time to adjust or doesn't have great family support, going to a skilled nursing facility can be helpful in a slower transition to being able to manage that at home. That sometimes that can be a colostomy, a new colostomy bag. Sometimes that can be a feeding tube. Um, Even different kinds of catheters. If it's going to be temporary and there's not enough support at home to manage that, a skilled nursing facility might be the right fit for that patient. When that is recommended, often your discharge planner, care navigator, social worker will give you a list to choose from. And we have to give you choice. And we are not supposed to make recommendations because, as you might imagine, ethically, we can't show favoritism. So there's a few different tools or questions and ways that I equip the families and patients that I work with to make a selection that's right for them. So the first and the easiest way to eliminate skilled nursing facilities from your list is looking at your insurance and what is in network with insurance. Medicare, all of the Medicare certified facilities take Medicare. So that's not as helpful in that scenario. But if there's a Medicare Advantage plan or a commercial insurance plan, what I would encourage everyone listening on this call to do if they're in that scenario is to ask the discharge provider, how do I find out which ones are in network with my insurance? There are ways that you can do that on your own. And often I will do that even before I give a list to a family. I will notice what their insurance is, and I will try to highlight the facilities that I know are in network. And I do that by if you type in the name of your insurance plan. So for example, if you have Johns Hopkins Advantage and you type into Google Johns Hopkins Advantage provider search, you will be able to, and the same thing for most Medicare Advantage plans, commercial insurance plans, you will be able to go onto their website and narrow down what is a list of skilled nursing facilities that take this insurance. So that is one way to narrow it down. But let's say we're Medicare and everything under the sun is an option to us. I tend to encourage people to look at geography. So for example, if you're hospitalized in Rockville, but you live alone in Rockville and all of your family is up in Frederick or even further, you might choose to discharge to a skilled nursing facility in that area so that your family or your friends can visit you there and help advocate for you while you're in the skilled nursing facility. So I think geography can often be important. But I think
Let me hear. We've got a gazillion questions and not all that much time, so I want to try to get to some of them, but this is super helpful. But so one of the things that came up before is, okay, so you mentioned that there has to be a safe discharge. And let's say a person lives at home and they live alone and they are not able to live independently upon discharge. And let's assume this example that they can't afford home care, which would be what we do. So what happens when there's not a safe discharge home?
Okay.
What does the hospital do? Are they stuck? Do they have to keep this person forever? What happens when there's nowhere and no one to help out?
So our job is to make sure that there is a safe discharge plan. So we do not discharge patients. We do not force people out of the hospital unless there is a safe discharge plan in place. Sometimes in a scenario like that, it might not be the most ideal plan in that patient's eyes. So if they really want to go home, most hospitals do not have the resources to pay for 24/7 caregiving for a patient indefinitely. But however, we do try to honor the values and what quality of life looks like. So I think it's important to know our job is to use our resources, our experience to help with the patient develop a safe discharge plan. One of the ways I think patients can advocate for themselves is if they foresee barriers. So, for example, you live with your daughter, but she is now going out of town for 3 weeks. So, there's going to be no help at home. Talking about that on day one with your discharge planner so that they know and they can help troubleshoot with you across those next few days to make a plan. The good news is there are other resources in place. I think for insurance that will cover for patients who have the resources, assisting hands and the other private agencies are often a great way to help a patient get home. There are other resources out there So, for example, adult medical daycare for someone who has more needs and perhaps some support in the evenings or early in the morning for friends or family who can come in. Adult medical daycare is a great
So
resource.
again, so part of your
Communities.
job,
Exactly.
people
Part
just
of our
know
job.
all the options that might exist.
Yes.
So
I
people are
want to
not
go back
stuck.
to your question before Steve though about the skilled nursing facilities because I think I left out the most important resource patients can look at to filter down. And that I think is maybe the most important is looking at the quality ratings of the skilled nursing facility. For Steve Gurney, this might be a website to put in the chat. Medicare.gov. If you look on the left, there is a tab for skilled nursing facility. And if you type in your zip code, you will get your own generated list of all the skilled nursing facilities, all the subacute rehabs in your geography, and it will have a number of stars next to each one. 5 stars are going to be the most highly rated based on staffing and quality, and the 1 stars are going to be the most low rated. There is a time and place for every facility on that list, and you take the ratings with a grain of salt. Sometimes they had a bad month 2 years ago, and Medicare just hadn't been back to reassess. But I think word of mouth and using that website are 2 resources that patients and families can use to narrow that selection.
Gotcha. So to get through some of the other questions, while I realize we're talking about hospital settings, I assume when someone's ready to release from a skilled nursing facility or rehab, there's a very similar process, that there is a discharge planner who has the same tools available to them to ensure a safe discharge home. I don't know if you could speak to
Yes.
that, but I'm assuming that's the case. Okay, so when someone is getting ready to release, is it you, the care navigator, who sits with the family and the client and says, here's going to happen. Here's how this is working based upon all of the things you've talked about and agreed to. You're that person that helps explain the discharge from home process?
So in most hospitals, it will be your nurse, or sometimes there's a designated discharge nurse because many of the instructions are medical. They're revolved around what medications to take, what specialists you need to follow up with. But we will also, and in an ideal world, we will meet with you every day or every other day to revisit the discharge plan for us to give you updates on whether those facilities you wanted me to refer you to accepted or said they're full. So we've got to look somewhere else. I might come to you for updates on whether your daughter received the delivery of the hospital bed or whether you've gotten a call from the home health agency yet. So we will not be the ones reviewing those discharge instructions.
Okay.
That said, we are keeping our eye on them because things that I personally am on the lookout for are there medications that if, for example, your usual pharmacy is Giant doesn't stock some things regularly that are commonly needed after hospitalization. Same with Safeway and some of the smaller pharmacies. So I will be on the lookout for what medications you need when you leave the hospital to make sure that that I can even call ahead in some cases. But that's some advice I'd give to the listeners on this call. Before you leave the building, I always encourage my patients to call their pharmacy so that we can get ahead of that. If there's any medications not in stock at your pharmacy, we can find one where they are in stock.
Great. So what's the big things, the bright lights? If you were to talk about the sticking points where people just, they're stressed, they got a gazillion things on, they're worried about everything. What's the things that go wrong? The biggies, like the top 2 things that you see that just didn't happen right and it holds up a discharge or people weren't prepared for. Are there some big lights?
Yeah, I think I want to acknowledge that this is, and I think we said this at the beginning, this is a very fraught time. I think when you're in the hospital or someone you love or know is in the hospital, we are not at our best thinking abilities in those moments, understandably, because a lot of our brain space is being used on understanding the medical. Because I think we're talking about discharge, but we have to remember there's a lot of medical need for being in the hospital in most cases. And that involves a lot of energy and time. And so I think my job as a discharge planner and as a social, and with my social work background, I'm constantly balancing the emotional needs of the family and the patient, but I am also a financial steward of the hospital. And the reason I have a job is because the hospital wants to stay open. And to do that, they are not going to be able to get enough money from insurance if there is not an acute need to be in the hospital. So I think one of the things that I struggle with is the availability of family members because they want to be there when the doctor is there. And then they also want to go home and shower. And of course, most of us are working. I'm sure most of the people on the call today, they work and they've supported someone in the hospital. And that's a tough thing to balance because you've got to keep your family fed. You've got to go to your job and your boss is expecting things to happen. So I think that that's very difficult. The things that tend to hold up discharge, I think, are sticking points that are understandable, but things that I help families work through. So, for example, if there's a very specific rehab that you want to go to, and that rehab, for whatever reason, is saying no, it's not something that we have a lot of control over. And over time, we develop relationships with these places and we could try to work things out by sometimes it's insurance, sometimes it's bed availability, sometimes it's they can't accommodate the need. That is often a sticking point that is tough to work through. And it's very tough because where you live, even if it's temporarily, is very important. And we all want to live in our first choice. I think another thing that's very tough in my role, and I think for my patients and families, is that we can't predict the day that someone is going to be ready for discharge. Sometimes we can, and myself, my colleagues, we've done this a long time. We can use our best guess, but I think things happen both ways. Sometimes everything will be in place for discharge on Wednesday, and the patient will wake up and be sick and not be ready for discharge. And so we have to reorchestrate everything all over again. And that can be very stressful. And sometimes it can be expensive if someone has secured private caregivers for that day. It also works the other way where we were expecting another 3 days. And whether it's due to lack of communication on the care team, but more often than not, it's just things happen that we didn't expect. We're ready on Wednesday, and no one was thinking Wednesday. We were all thinking Sunday. And that can be very hard. I think what's important to know, because I think a lot of people who present in the hospital have Medicare nowadays or a Medicare plan. And it's very important to know that if you don't feel comfortable with your discharge, because I think most of us, because of medical, we're willing to bring that up with our doctors, but sometimes you remain in disagreement. You have the right to appeal a discharge if your status in the hospital has been as an inpatient with Medicare. And that's an important tool. And hospitals are required to inform their patients at the time of admission and within 48 hours of discharge that they do have that right. And that can apply to safe discharges. If you truly feel a discharge print is unsafe or not adequate, that is a tool at your disposal as well.
That's a great point. A great one that people really need to keep in their minds as they're looking at discharge. There are options, and you don't just have to shuffle along and do if you don't really think it's the right thing. So a couple other questions. So I'm assuming, just as you have lists of rehabs and skilled nursing, you also have lists for assisted living communities and home health care, that you can also make some generalized recommendations as to whether or not someone should consider assisted living communities or someone should look to get some added assistance at home.
So assisted living is a little different because I think it's hard for us, and almost my whole career, at least in the Montgomery County area, has been working physically inside hospitals. And it's very hard. Nowhere out there is there a comprehensive list, or maybe there is, of all the assisted livings. And I think there's a huge range with assisted livings of what kind of support they can provide, what medical complexities they can handle, of cost, of geography. So we actually rely very heavily. And there are cases where we discharge directly from assisted living from the hospital when there's not other options and a family is able and willing to engage in that process, which can be done quickly, but often can take a while. There's many agencies in the county and across the United States. I don't know what you call them, agencies, companies, where they have people and their job and their expertise is what's available in the area. So you give them your price range. We send the clinicals from the hospital, and they can make recommendations and do some work behind the scenes to make a proposal or narrow it down to 3 in the area that you can then look at. Over time, I've made a lot of connections, but what we tend to be more familiar with are the bigger ones that we drive by every day or that advertise. But there are many very good licensed smaller assisted livings that we just don't know about yet. And that's why it's very hard for us to present choice and still on these third parties.
So in those instances, people would call an aging life care professional or a placement specialist, because there are any number of people that provide different levels of support depending on what people need and what they're willing to pay versus not pay. And so, those folks are available out there. I'm assuming that you may or may not know of some of them and can make recommendations. Hey, you could try calling these folks.
Absolutely.
Certainly someone can Google aging life care managers and an array of folks will come up. There's the same thing with the placement teams. There are a number of really good folks in our area that can also assist in discharge. And there was a question about someone working in Colorado and does this apply nationwide? And the answer is generally speaking, yes. This is, while we're giving some specific resources, hospitals in the United States all have similar guidelines and protocols for discharge. So while we can't speak to specifically what happens in Colorado, we can say generally speaking, this is an approach that is out there and you can think about on your own. That's it. So I think we addressed one of these. I've heard that patients are not given enough information to make an informed decision about what skilled nursing facility to go to. How soon is the patient made aware that they will need skilled services? And I think you answered it by saying it really just depends on how quickly it comes up, and it's an ever-changing world. Sounds like your goal is to give people as much time as possible within to make a decision. I don't know if you have any more to add on that.
Yeah, I think when that initial meeting, often what I will ask is, what do you think, if I'm not talking directly to the patient, what do you think your mom, what do you think your dad's goals are? What if he can't walk when he leaves here the way he was walking before? What do you think he would want to do? And a lot of people already have rehab experience or have loved ones who have been to rehab in a skilled nursing facility, and they say, that is not for me. What would I need to do? Or if they don't ask, I will say, here's what I think you might need to do in order to have a safe discharge to home. So we get that ball rolling on day 1 or day 2, ideally, because otherwise, if we're waiting for a physical therapy evaluation, we might be waiting until day of discharge, and we can use our eyes and our ears and talk to the bedside nurses. But I think also the patients, you know your body. And if you haven't been out of bed and you tell me that, then we're having a conversation with the nurse today. We've got to get out of bed to see what we can do. That said, I think in most cases, it is always going to be safer to not go home to an empty house. So I think on day 1, if we know we're going home, even if you're walking more or less fine and nothing really is going to change, I always recommend talk to your brother, your sister, your girlfriend, your siblings, your children. Can someone come and spend the night with you just to get you through that first 12 hours, 16 hours? Because I think a lot of times we think, gosh, everything will be fine as soon as I'm out of this hospital. But often we're not feeling 100% when we leave the hospital, right? We're out of crisis, but that doesn't mean we feel all the way better. And I think it's always good to have that extra safety net. A lot of hospitals, a lot of private caregiving agencies are now offering hospital to home where you can hire someone, or even often the hospital will pay for 4 to 6 hours of someone to help you get home, make sure your fridge has groceries and that your medications were picked up from the pharmacy. And I think that those are really valuable resources.
Right, and that's where I'll give a little bit of plug for home care generally. So while Assisting Hands does home care, there are, at least in Montgomery County, probably over 250 home care companies. So it's not just Assisting Hands. But one of the things that we often do for people is we're available for maybe the first 2 to 3 days after a person gets back home, especially when someone's been in the hospital or a rehab for months or a month. Home is disorienting. There's no good food in the fridge. And if there isn't someone there that can clean out the old food, restock it, make sure that the meds go to the pharmacy and pick up medications, it's a recipe for someone to readmit back to a hospital. And so we often encourage people to look to home care as a temporary solution. If family members aren't available, to come in for a few days. Sometimes we work 24 hours and then we're done. Sometimes we may work 2 or 3 days, decreasing down so it's part of a day, and then we're done, to help people sort of transition back to their home life. Because oftentimes, if it was an emergency, someone left the home and it was a wreck because they left on a stretcher. They didn't plan to leave. And if they don't have family members that can go there and prepare the house for a return, that's when home care can oftentimes be very helpful. Something that we can do to help the hospitals make sure people get home safely, stay home safely, and don't readmit because they're eating, they're drinking, they're taking their meds, they're getting a safe shower that first time they're home. There was a question about, do care navigators, are they agitated if there's a professional? I think someone answered that said that you're welcome having third-party professionals involved in helping with the transition. There's no jealousy, and you're looking for partners, whether it's family or professionals.
Absolutely. We will always, though, best practice is to always call the patient or family first and make sure that they want us giving information to those outside care managers, because we do have to respect, there are laws, but also ethically, we respect a patient's right to self-determination. And if they don't want us talking to a third party, they want it to go through them, that's great. But we welcome support. We welcome the community expertise.
Gotcha. And I think we're probably heading towards wrapping. We have some time for a few more questions, so I'm scanning through. I think we've probably answered the bulk of them. So one question came up earlier. It related to a different hospital system, but the thought is the same. Oftentimes, everyone now has a portal. And so I'm going to assume that you all have a portal and that patients have access to information. Does your discharge plan go in the portal? Is it available to other people? How do people, I know you get a big packet of paper when you leave, but where else can that information be found if other places?
That is a great question. I don't have a ton of visibility into patients' portals. I actually can't even access the patients' portals at a dentist. I think the way, in my experience, the portals tend to be used more in the outpatient setting. And that's from the several hospital systems I've worked at. That said, I do encourage, if family members feel that they're not, for example, getting the lab results in time for what, and they want to keep a better pulse on what's happening in the hospital, I will encourage them to make a patient portal account, because you can see, and I've been told that people can see my notes in the patient portal. I imagine that would include the discharge plan. But what I mean by discharge plan is the discharge instructions that the nurse is going to print out and hand to you. That often does not include every element of the care plan that I have discussed or your discharge planner has discussed with you. If there's a home health agency that's going to be showing up at your house in 2 weeks, best practice is for us to include the name and a phone number for you to reach out to if you don't hear from them within 24 to 48 hours. I would say, though, that most patient discharge planners are not utilizing the patient portal in that way, but it can be to keep a pulse on the medical results that are popping up and you might not know about right away while your loved one is in the hospital.
So we've talked about, I'm going to put you on the spot a little bit, and I apologize because you must be exhausted from all these questions right now. But so we've really talked about the ideal. What happens when things go right? Hospitals are like anybody, any other business. Lots can go wrong in the process. So what happens when it all goes wrong and there isn't a you that's being as thorough and as engaging to clients or to patients? How does someone advocate for what the ideal should be?
Yeah, I think that's really important. I think that floating around on the internet, if you Google, I think there are some that are better than others, but like discharge planning checklist. I know Family Caregiver Alliance at one point had a good one with questions that you can ask to advocate and to get the information that you need. Because I'm a social worker, I'm not a nurse. Sometimes it will take me a while to look at what's happening in the hospital and be able to anticipate certain more medically oriented needs that we get them in the end, but I can't always anticipate those on day one. Day one or day two, if you're not seeing someone who introduces themselves as a social worker or a discharge planner, I think asking your nurse, who can I talk to about what happens when I leave here? And that the doctor is very important for that, but the doctor is always going to defer all that logistical stuff to my team. I think asking the doctor, though, your hospitalist, or if your oncologist is really running the show, your neurologist, what are you looking for to happen prior to me discharging from here? And you might get answers like, I need to see how you tolerate this treatment and then I can send you home on it. Or we need to wait for the cultures to come back. Okay, how many days do you think it will take the cultures to come back? That will help you get a sense for the timing. It might be you have a surgery coming up during that hospitalization. What will happen after the surgery? Will I get physical therapy after the surgery? Will I be expected to leave within 24 hours after the surgery, which happens sometimes? But I think helping yourself get a sense of what is in the doctors and the care team's head. Um, and then I think starting to ask about if they were to go home. And these are questions you can ask the doctor. So let's say your discharge planner is MIA. We don't know where they are, or they're shy, they're new, they're not asking you as many questions as you feel like they should to get information they need. You can ask them, but same question for the doctor. If they go home, what exactly will they need? What will be different? Are they going to have wound care that they need? Because now there's this new wound. Are they going to need intravenous antibiotics? Those are just some things. Are they going to need supervision when they walk because they're at risk of falling because of a new medication or from just getting weaker and having less endurance from the hospitalization? And I think along the same veins, okay, so I know that's what I need. What support am I eligible for at home? Because for most of us, we want to know what our insurance is going to cover so we can take advantage of that. And we also want to know our options. There are some things that won't be covered in the house, but a skilled nursing facility will cover those things. So at that point, we might use some information and decide we ultimately want to go to a skilled nursing facility. And then finally, I guess another question I would ask, and I think this is really important, even if you are discharging to a rehab facility, is who am I going to need to follow up with after this hospitalization and when? I do hear, unfortunately, from many patients that, they discharge from the hospital to rehab and they never really get to see or they never have access to those discharge instructions that they would have had if they were to go home. And same thing, I think helpful to know before the day of discharge and the minute of discharge, before you're handed that packet of papers, so you can go ahead and schedule that follow up appointment with the heart clinic or with your neurologist so that there's going to be decent continuity of care. You might want to schedule an appointment with your primary care doctor because if you're being prescribed new medications and they're only going to last you 2 weeks, you need to make sure there's someone who's going to be able to refill those. But those are just some questions that come to mind, and I'm sure there are others for things that you can ask to help yourself get some of that information too.
So here's one other one. Obviously, you have clients that come in, some are cognitively intact, some are less, but even the ones that are cognitively able to make decisions, I know, for example, my folks, they came from a generation where if a doctor said something, they just did it. They didn't ask a question. They just, oh, okay, doc. Is there a way to put in someone's chart that you can't just discuss this stuff only with mom or only with dad? You have to loop in one of the kids, because sometimes I think decisions get made because someone came in and talked to mom or dad and they weren't thinking about all the ramifications. So they just said, okay. And the kids are like, well, what are you thinking, mom? That's not even likely scenario. Is there a way to guard against that or protect it in some way so that there's really the family is included to help make the decisions? Again, assuming the client is up for agreeing to that.
Yeah. And this is when you ask me, I think, what are the hardest parts or what are the hardest things that happen? I think this kind of a scenario is one of the hardest that we navigate because our job, and I'm a social worker, I've got my social worker at the client's right to autonomy, to self-determination is so valued in my profession. And I think also in a hospital setting, because all this stuff is happening that you don't want to be happening to you and you just want control. But I think, for someone with capacity, right? Because if there's no capacity, we very much rely on an advance directive, on durable power of attorney documents to know who in the family or in the community are we supposed to be reaching out to for decision making and discharge, medical decision making, and also discharge planning for this patient. In the case that there is capacity, our role, I think if we're doing our job right, we are also asking in that initial assessment, who is your support at home right now? Do you make your food all on your own? Do you drive yourself to appointments so that we can gauge, or is everything all on our own at home, or is there someone else in our life? Because if there's someone else in our life, we need to make sure that that person is going to be available on the other end to do that and potentially more. So I will suggest if there is someone who seems very involved from that questioning and they're not there in the room at that time, I will suggest we get them on the phone in that moment. As you said very accurately, many people, and I think we think of older adults, will be resistant. I hear a lot, don't call my daughter. She's busy at work. And it's just a very delicate balance where we try to not convince, but explain why it might be important in this situation. In most cases, we will find a way to involve the family. What I hear a lot from patients and families is that the doctor is coming in because when the doctor rounds, they're there when they're there. They don't come back in 5 hours when you're home from work. And so a lot of times what I hear is it's very hard for families to keep a pulse on what is going on if they are not in the room at that moment because mom won't insist to get son on speakerphone while the doctor's in the room. And then you're missing that information that helps you know what's going on medically, never mind what's going to happen with. And I think that's very hard. I've had a lot of families of them to make signs to put on the door, must call with the patient's permission, must call Harry on speakerphone, must call Harry to let them know what's going on with the phone number. I
That's a
think,
great tidbit
yeah.
for
Yeah, I
people.
think right now I'm a big fan of writing signs with permanent markers and sticking them on the walls. We do
like
that a lot.
I like it. So there's a question here that says, who does the assessment for what's needed at home? And I think the answer is, you check me if I'm wrong, generally speaking, people are relying on the patient or the patient's families to be accurate self-reporters of what their home environment looks like. You all aren't going out to the house and evaluating, are there 5 steps up to the front door? But is there a service that we're aware of where does go out and walk the home to make sure that someone didn't forget there are 3 steps into the house and they're now in a wheelchair?
And I think you're right. We are asking, and mainly the physical therapists in the hospital, but often as we're asking, if we notice there's a change in mobility or you've had support and now that person's out of town for 2 weeks, how do you get around in your home? Are there stairs? Or how far is the bathroom from your bedroom? So that we can, in the moment, make a plan with you. Okay, so it sounds like you're going to need someone to be there when you get home to help you up those stairs. Or in a scenario where rehab's been recommended and someone lives alone and they're saying, no, I need to go home. It's a way, knowing that information is a way. Okay, so you're going to get home and there's 3 steps. How are you going to get up those 3 steps? That's a tact that we use a lot. But that is one thing that we rely on home health agencies a lot because the goal is their safety at home. But you also, if there's a change, you want to make sure that the home grows with you in whatever direction you're going. So that's a good thing that home physical therapists, occupational therapists do is they can make recommendations. And one of the reasons I will refer to them is to make recommendations for home modifications. If you look in the source book, though, I do know, and I've relied on them before, there are many companies and nonprofits that will come in and not only make those home modifications, but do assessments for you if there's someone in the family or your neighbor who you're worried about.
All right. I think, Jenna, you have provided a wealth of information, and I so appreciate you taking the time. This has been amazing. I think you've answered all of the questions, tough ones and easy ones. So thank you for your time today. This has really been good and fabulous talk. Steve, thanks again for hosting this. To me, we can't do it without you, and we can't do it without people like Jenna who offer their time to help explain what's going on out there in the community to help make sure people are well educated and are discharging home safely. So thank you both.
I love it. And just as a reminder, folks, we'll post the recording later this afternoon at proaging.com. I'll make sure to send it to Steve and his team too. And boy, I tell you what, Jenna, we could probably have you back every month because there's so many details in what you and your colleagues are doing. And this is such a confusing process. It's not one that anybody wants to go through, but they appreciate it when there's team members like you all to help them navigate it.
Thank you for having me. It was such an honor to be here with you all. Thank you.
I love it. All right. Have a
Steve,
great
this
weekend.
concludes this quarter's edition of What You're Playing by Assisting Hands Home Care. So much for hosting. And I don't know if we have a topic yet for next quarter. I know Patricia, who is our master organizer of all things, and is brilliant at community engagement, finding insightful topics and great speakers. I'm sure she's on it if we don't have something. But so thank you all.
I love it. All right. Stay tuned. Have a great weekend.
All right, Jenna, again, thanks so much.